Yeah, Gordon, I think you need to pause the recording. I think Felix is gone off. Yeah, Felix, we can hear you now. You want?
Sorry. So I dropped off. I don't know what happened. I hope it's not the internet. Okay. All right. So I was saying this will be the outline for the today's presentation. So what's happening? Okay, good. So arrhythmias generally abnormalities of heart rate regularity or the site of origin of the cardiac impulse or a disturbance in the conduction. And usually will lead to an abnormal sequence activation. And amongst the arrhythmias we have asystole, we have extrasystole, we have bradycardias. We also have tachycardias, ectopic beats, escape beats, which usually are sort of beats that occur or impulses as a result of a sinus node failure, especially when the normal pacemaker activity is not or is malfunctioning. So the reason why these occur, we'll look at that. But basically, the cardiac conduction system consists of a group of cardiac muscle cells and conducting fibers, which are also special cells. And the function of these is one, to initiate impulses and to conduct the impulses through the heart. And what happens is that the initiation and the conduction usually happens in a well coordinated or orchestrated fashion, which leads to synchronous contraction of the cardiac fibers and then the cardiac chambers that are involved. And it is the cardiac conducting system that provides the intrinsic cardiac activity that we have. And the heart, we can say, is a functional syncytium. An example of a syncytium is, let's say, the muscle fiber in which you have within, and then this helps them to contract in a coordinated manner. However, the cardiac or the heart, it's not like that. Instead, you have individual fibers that are interconnected, and that makes it like a functional, that makes it a functional syncytium. So it behaves like a syncytium. So that if you look at the picture that is shown, we have coordination between all the cardiac muscle cells through what is called the intercalated disc. So the intercalated disc actually contains the gap junctions, and then we have the desmosomes that are also present. So the gap junctions sort of are pores in between the cells, so allows cardiac, the heart functions as a syncytium, and I was explaining how that came about. And that is mainly because of the intercalated disc that we have. Which consumes that it doesn't happen again. I've changed the ISP. So the advantage is that it allows rapid synchronous depolarization of the myocardium. But then the disadvantage occurs if there is a problem, which means that once you have an abnormal propagation or impulse, it means that it is also going to what? Depolarize or spread in a synchronous fashion. In a synchronous fashion. So that is the disadvantage of it being a functional syncytium. So the cardiac conduction system, we all know, consists of the sinoatrial node, the internodal tracts. We have anterior, the middle, and the posterior. We have the AV. So the node acts as the primary pacemaker of the heart. So we have also what we call the ion channels, and these sort of are involved in the action potential of the heart. So they actually are transmembrane proteins that allow particular ions to go across them selectively. And these ones would actually go in one direction or the other. So it favors flow through one direction or against another direction. So sort of what we call a lean non a rectifier. So that is what leads to what we call the rectification. The reason is that it allows you to flow through one direction only, but not in the linear fashion, so that when it gets to a certain voltage,
Hello, Dr. Felix.
then the flow of that current
Dr.
actually
Felix.
changes. So it
What
might
is it
slow
taking
down
off?
or it blocks it out completely. So it is the opening, the closing of these ion channels that give us what we call the transmembrane potential that we have. So, and these are very important. Generally, there are 6 different types of ion channels. The sodium channels, the calcium channels, we have the potassium, and they are the highest in number. They have funny current channel. That's it. Hello.
Yes, Dr. Felix, we are still struggling to hear you clearly.
Yes. I don't know what's happening today. Let me make an adjustment quickly
Okay.
and see if that will work. So just give me a minute or
Okay, thank you.
Gordon, hello, Gordon.
the ion channels, like I mentioned. So the fourth one is the funny current, and then we have the chloride, which usually plays a lesser role in terms of the cardiac action potential. And then we have the secondary messenger-gated potassium channels, and these ones are usually regulated by ATP and then acetylcholine, and those are the muscarinic potassium channels we have. So this is a list of the various ion channels we have in the heart involved in the cardiac action potential. So the membrane potential of the cardiac myocyte is based on the concentration of ions in and outside of the cell. And this is what gives it its membrane potential. And then this is maintained by the permeability of the cell membrane to the various ions that are involved in the action potential of the heart. And then we have these pumps, and these are sort of transporters that are involved in maintaining the ions across these cells. We have the sodium, potassium, the sodium, calcium, and then there's an active calcium transport pump that is also involved. So what also happens is that because of the gap junctions that are available, you can have flow of ions in between cells that can also influence the membrane potential of the myocyte. So the table below actually shows us the differences in the resting membrane potential and the amplitude of the action potential that we have. So we'll notice that the sinus node, for instance, its resting membrane potential is -50 to about -60, whilst the ventricular muscle is about -80 to about -90, which is more to the extreme. So this is a diagram of the cardiac action potential that we have. So this sort of depicts the movement of the main ions that are involved, the sodium, calcium, and potassium ions across the membrane. And this is what actually keeps the inside negative and the outside positive, and then creates the membrane potential or the charge that we have across it. So if we look at let me use the pointer. So if we look at this part, this is the resting membrane potential, and then that is -85. But once the sodium channels, okay, open, and what they do is that they allow sodium channels to come into the cell, and they get activated at a certain membrane potential. Okay, so if that membrane potential is not reached or breached, then these sodium channels are not activated. Okay, so around this action potential, they are sort of activated, and they open rapidly, almost at once. And what happens is that because they open rapidly, the inside of the cardiac myocyte instantly becomes positive up onto 0 and overshoots. And once it overshoots, okay, what happens is that up to a certain voltage or amplitude, they are inactivated. And once they are inactivated, what happens is that because the other channels are also working somehow, there is a dip. So there's a slight dip because they have been closed or deactivated. So what means is that the flow of positive ions into the cell has ceased. So you have a dip in the membrane potential, just to about 0. And around this time, you have the calcium channels that are open in phase 2. And then you also have potassium channels that are also being open. And the balance, the counterbalance, if you come down here between the calcium and the potassium ion channels, gives us the plateau phase of the cardiac action potential. And then the calcium ions are actually what they call slow rectifying. So they activate slowly. So that also helps to keep it more of a plateau. Up to a certain stage where they are fully activated, then they trigger the opening of the rapidly inward activating potassium channels. And that leads to a rush of potassium into the myocyte. And that's a rush of potassium outside. So that is outside, sorry. So outside means that it is taking the negative, the positive out of the cell to make it more negative. So they open up, and then the potassium cells, ions sort of flow outside. And that leads to the cell becoming negative again. So it goes all the way through phase 3, comes to -85, and it actually goes down to what is referred to as hyperpolarization, Once it gets to phase 4, what happens is that it triggers the pacemaker cells. And that is because the ion channels in them are activated when there's hyperpolarization. And then that slowly again depolarizes till it gets to the potential that activates the sodium channels. And again, those open up. And then there's an influx of sodium. And then another action potential is achieved. So basically that is, but we'll go into the main details. So the phases, we know there are 4 main phases. That is 0, 2, 3, and 4. 0, 1, 2, 3, and 4. So you have phase 0, phase 2, phase 3, and phase 4. Usually the what we call the early repolarization is phase 1, but we don't talk so much about it because we don't really have a lot of activity going there. But then phase 0 is the upstroke or the rapid depolarization of the action potential. And like I said initially, dominated by sodium channels entering into the cardiac myocyte. Then we have the early repolarization phase, which is the initial rapid repolarization. And like I said, that is caused by inactivation of the sodium channels. Okay. And then there's that activation of the transient potassium channels, but mainly is due to the inactivation of the sodium channels. And then that sort of slows down the rate of positivity, and then it drops a bit. So this is a diagram outlining it more clearly. So we have phase 0, where you have this phase 1, and then we have the phase 2, and then phase 3, and then phase 4. So the main channels ions we need to remember is sodium 0, sodium closing, phase 1. We also have these transient potassium channels that also open shortly, and they are transient, so they open shortly and close. And then for phase 2, like I said, it's a counterbalance between what? Calcium channels and potassium channels. So you have calcium influx and potassium what? Efflux. And the potassium efflux is due to the delayed rectifier current. So they are a bit slow in terms of their opening and activation. So they do not do that rapidly. And then you also have the influx of calcium channels through what we call the long L-type. That is a long lasting. Okay, so they stay open for a long duration, whilst these ones are also activated slowly. So there's a delay, and that's what gives us an electrically balanced membrane potential, and that is a plateau. And this is a period where it is refractory. It is resistant to any potential that you might try to induce in the myocyte. Then we have phase 3. Phase 3, the calcium channels close, which means that you do not have positive ions going into the cell. Okay. But what happens is that the delayed rectifier, like we said, are slow. Okay, but they remain open. And then you have rapidly activating potassium channels that are also activated. And those lead to what? Efflux of the potassium from the cells. And this contributes to what? Returning the membrane potential back to minus 90 thereabout. Okay. So I think I've explained this already. So we'll just move on. Okay. I've explained this already. Okay, so based on the characteristic of the ion channels involved in the cardiac myocyte, then we have a characteristic action potential. So the common one that is used in teaching is that of the ventricular muscle or the Purkinje fiber action potential. And that actually has 4 phases. But the sinus node, the atrial muscles, AV node, have a characteristic of quite similar cardiac action potentials, and that is because of the ion channels that are involved in the generation of their action potentials, and we'll look at that shortly. So the cardiac action potential, if you look at this, let's go to this diagram. That's a sinoatrial node. It tends to have 3 faces, okay, instead of the 5 faces that we have in the ventricular muscle action potential. The AV node also has a similar profile, but then the atrial muscle sort of has something that is similar to the ventricular muscle action potential. But what happens is that it actually has these rapidly activating potassium currents. So they sort of push it back to negative membrane potential as soon as possible, compared to this that you have the delayed rectifier potassium channels, which open slowly. But these ones actually open fast and result in a negative membrane potential. But then the sinoatrial node, like I said, has 3 phases, okay? It has phase 0, phase 3, and the phase 4. It lacks phase 1 and phase 2. Okay, so in phase 0, the SA node and the AV nodes, okay, there's an upstroke, okay, and once it reaches -40, there is depolarization which occurs. But then what happens is that the depolarization here is not by sodium ions. It is rather by calcium ions via the T, those are the transient, and the L-type calcium channels. So one thing we have to remember, 0 in the muscle is sodium, but 0 in SA and AV node is calcium. Okay, but this is actually a slow activation. So from hyperrepolarization, there's slow activation, and then to -40, then there's activation of the calcium ions or calcium channels, and this leads to phase 0 of the action potential of the sinoatrial node. Okay, then, so remember there's no phase 1, there's no phase 2. Okay, so it goes up and then it comes down back to 4. Okay, so phase 3 is just repolarization, and that is by closing of the calcium channels and opening of the potassium channels. Okay, so efflux leads to rapid return. But what happens is that it comes down to -60. Okay, -60, and that is sort of a hyperpolarization for it. So once it crosses its membrane potential, there's a slow activation of the sinoatrial node again, and then that leads to another depolarization. Okay, and the channels that do that, okay, the channels that do that are what we call the funny sodium channels, the IF channels. Okay, so what happens is that they are activated automatically, okay, sort of, and this is because they have unique characteristics, and that's why they call them what? Funny. Okay, so once there's hyperpolarization, they are activated and they actually open. And one of the things that make them funny is, 1, the hyperpolarization that opens them. 2, they have sodium and potassium channels. Okay, they have sodium and potassium channels that open. So these ones sort of open and then allows depolarization slowly. And then once they reach the threshold of the calcium ions, which is -40, the calcium ions channels open, and then there's rapid depolarization. And that's generally what makes them funny channels, because they behave in a peculiar fashion. Okay, so I think that is well explained. Let's see. Okay, so we can move on. All right. So the other thing I need to mention is that the pacemaker, that is the IF channels, are affected by one, ATP, that's the acetylcholine channels, which I mentioned earlier. That is the acetylcholine mediated potassium channels can affect these funny or IF channels that we have. And that is the mechanism of the action of ivabradine, the medication ivabradine. So ivabradine sort of inhibits the IF channels, which leads to slowing down of the heart rate, because that is a pacemaker of the heart. So once ivabradine is given, it slows down the activation of the sinoatrial node, and that can lead to slowing down of the heart rate. In addition, calcium channel blockers also affect the calcium channels that are involved, and then beta blockers are also involved. So that is how come these are given to slow down atrial rates. Okay, so this diagram just depicts the different ions involved. So we said sinoatrial nodes, we have the funny currents. So there's a sodium, and then there's also potassium. Then we have calcium here, and then potassium opening to bring it down again. Then in the myocardium, we have potassium keeping it at 4, sodium taking it 1, potassium sodium 0, potassium 1, calcium 2, and then potassium 3, and then 4, potassium also. So this is the basics of the cardiac action potential that we have. Okay. So if we talk about the cardiac action potential, we need to mention some concepts. The concept of effective refractory period. Okay. So what happens is that during this period, the action potential is refractory. That is resistant to another action potential. Okay. Or a stimulated action potential. Okay. So there is an effective, in which during this period it is completely or relatively refractory. But then there's the absolute period. Okay. And if you watch carefully, the absolute period is completely refractory. There's nothing that you can do to stimulate another action potential. That is the idea. And the effective goes beyond that slightly. Okay, goes beyond that slightly. And during this absolute, what is known is that the sodium channels are completely closed. So there's nothing that you can do to open them to cause depolarization. But then the effective period includes a phase where the sodium channels begin to recover from their deactivation. Begin to recover from their deactivation. And remember that it is at a certain voltage that some of these channels begin to be activated. Okay, so as it goes down to about -40, some of the sodium channels are being activated. Okay, so they begin to open. So that is where somehow, if you have a stronger stimulus, you could stimulate another action potential. Okay, then there's the relative refractory period where more sodium channels have opened, and that is till it hits phase 4. It is a period where you can actually generate another action potential, but not so easily. And then there's the supernormal period. Okay, and during the supernormal period, we all said that the sodium channels can be activated. Okay, at a certain voltage. So it means that as it's coming down, more sodium channels are being opened. So it means that at this supernormal period, you have quite a number of sodium channels that are open. Okay, and there's less inward current. Okay, but then it means that if there's another trigger, because quite a number of the sodium channels have almost recovered, you can trigger another action potential. And that is a period that is critical. Okay. Then let's move to the right. If you watch carefully, the ECG, this is a T wave. So at the peak of the T wave to the lower limb, so the peak of the T wave between that's the ascending limb of the T wave is actually what? Let's say from the QRS complex to, that is from the J, that is from the J point to the rise of that's the upper limb of the T wave up to the peak is the effective refractory period. And then before the limb, that is the what? The absolute refractory period of the action potential. Now, when you move down the descending limb, then you have the relative refractory period, and just after the T wave is a supernormal. And that's why you can have the R on T phenomenon occurring at this point. That's why we can also have commercial cordis occurring at this point, because at this point, if the stimulus is high enough, it can trigger another action potential, and that can lead to an arrhythmia. So in commodis cordis, that is why typically it happens here. And then the R on T phenomenon typically also happens here because of that. Okay. So we'll now look at the mechanisms of arrhythmia. So we have bradyarrhythmias, and bradyarrhythmia is generally due to a reduced impulse formation or a reduced impulse conduction. So it is not formed, or it is formed, but it's not conducted. And then when we look at the tachyarrhythmias, we have also disorders of impulse formation and then disorders of impulse conduction. So for impulse formation, we have automaticity and triggered activity. And then for disorders, basically those are re-entry phenomena involved with conduction. With the triggered activity, we have what we call the early after depolarization and the delayed after depolarization. And then for the re-entry, we have anatomic and functional mechanisms. So for the bradyarrhythmias, reduced impulse formation means that the cell membrane is hyperpolarized. Okay, and that is why the SA node is unable to do what? To trigger another action potential. Okay, so even though the IF channels might be sort of activated, it is hyperpolarized. So there's no way that you can have it coming back to positive to trigger that. And typically, hyperkalemia is one of the causes of reduced cardiac impulse through hyperpolarization. And we all understand that more potassium not in the cell, but out of the cell. Okay. Then we also have reduced impulse conduction. Okay, so whenever there's impaired communication between these cardiac myocytes, then you can have reduced impulse conduction. And this can happen from myocardial infarction, which sort of causes damage to the energy requirements. So ATP, loss of ATP, ion channels are non-functioning, gap junctions have been disrupted. So that this can lead to impaired conduction of action potential. Okay. So I mentioned some of it earlier on. So for the SA node, for instance, if you give a beta arrhythmic or norepinephrine, for instance, what happens is that it actually, if you look at the green line, it actually pushes the threshold more towards a positive, more towards 40, which means that the SA node can easily be activated and action potential can be generated easily. The dark blue is a normal one. Acetylcholine, on the other hand, which is parasympathetic stimulation, depresses the threshold further, which means that it is far lower than the threshold here. So it takes longer for the IF channels to reach the activation threshold for the calcium channels. Okay, so that is how the sympathetic and the parasympathetic would affect the heart rate. We either cause a bradyarrhythmia or a tachyarrhythmia.
How are you?
Then
How are you outside?
I mentioned improper communication between cells,
Yes, somebody.
result of damage to the cells. Okay, so one is that when there's insufficient depolarizing current, okay, so the normally polarized, so what happens is that because of disruption, okay, the depolarizing current is insufficient, okay. It means that there's a bit of refractoriness to what is normally activating it. Okay, so and that can come as a result of, like I mentioned, damage or uncoupling of the junctions. So it means that current doesn't flow easily through the gap junction to the cell near it. So it sort of remains quite refractory. Okay. Then when you have myocardial infarction, for instance, there is damage to the sodium potassium ATPase channels, and that also affects flow of channels across. Also the sodium calcium exchanger or the pump, that can also happen. So myocardial infarction can lead to what? Reduced impulse conduction and lead to a bradyarrhythmia. Okay. The other thing is that the repolarizing current, it's too high or too much to be overcome. So the effect of adenosine in the AV node, okay, like I mentioned earlier on. So what actually happens is that there is a depression of the membrane potential. Okay, so even though there is a conduction that is occurring, the interface between the sinus and the atrium, there is a problem there. So so you can have that in SA exit block, and that contributes to tachycardia syndrome. Okay, the SA node produces the impulse, but then it doesn't get to the atrial muscle. Okay, then there's also depression of conduction within the AV node itself, and that is where adenosine effects in the AV node sort of happens. Okay, then we can have second degree or third AV blocks also occurring. Okay, then sometimes there's absent conduction in the Purkinje system. Okay, so we have that in bundle branches and then hemi blocks occurring. So in the tachyarrhythmias, I think we've gone through this already. Automaticity can be because of altered normal or abnormal. Okay, it's normal, but it's altered. Okay, so when we say abnormal automaticity, it refers to the development of spontaneous depolarization during diastole that induces an action potential. So during diastole phase 4, we don't expect any depolarization. It needs to happen as the SA node deems fit. But what happens is that we can have what? Spontaneous depolarization happening during this period. And that happens easily more in the SA node cells than around the SA nodal cells, the AV node, and then the Purkinje system are the last to have abnormal automaticity. Okay. And that can be because of abnormality in the mechanisms that maintain the membrane potential. Some people have a mutation in the funny currents, which can lead to what? Abnormal automaticity happening. So that is possible. On the other hand, some substances can also stimulate spontaneous firing. And I mentioned norepinephrine or the sympathetic system in terms of the SA node. So catecholamines can do that. Hypoxia acidosis can also do that. So these are substances that can stimulate what? Abnormal automaticity. So, so the first one, this is the normal thing we expect. But what happens is that it becomes abnormal, and then you'll notice that instead of it being prolonged, it becomes shorter and shorter and shorter, and that gives us what? An abnormal ultimate cystity. It means that it is discharging. There is a node is discharging abnormally. Okay, and then this is also another that is happening, and here what we see is actually an ectopic pacemaker activity. Okay, and again, catecholamine excess, like I mentioned, can do that, and then post-myocardial infarction can also do that. Then we have triggered. So let's say that for the abnormal or normal automaticity, that is what. So you can have normal automaticity. It is not abnormal, it's normal. Let's say physiological. So let's say a patient has fever, has anemia. It's not abnormal, but because of the physiological parameters that are happening, the heart rate sort of increases. So those are not usually abnormal automaticity. Okay, they are enhanced, sort of. Okay. So triggered activity, I mentioned delayed and early after repolarization. Okay. So with triggered activity, it is any action potential that is generated, okay, after depolarization has occurred. Okay, after depolarization has occurred. So anything that happens after depolarization is referred to as a triggered activity. Okay, and this happens because the membrane potential, the membrane potential sort of changes or shifts. So once it moves up towards positivity to a level, and remember we said some of the ion channels are recovering, then it can trigger an action potential. Okay, and like I said, you have one, it can occur before it gets to 0, phase 4, or just when it's on phase 4, you can have the triggered activity occurring. Okay, so when the action potential has not fully repolarized, then it is referred to as early after depolarization, and that you can have there are two types generally, and then you have a delayed after depolarization. That happens after the action potential has fully repolarized. Then you can have the delayed after depolarization. Okay, so with the early after depolarization, I mentioned there were two. So there's the phase 2 and phase 3. Okay, so the first one occurs during phase 2 of or around phase, just towards the end of phase 2 of the cardiac action potential. The second one occurs during phase 3 of the cardiac action potential. And then we have the delayed after depolarization, which happens after depolarization is completed. Repolarization is completed, sorry. So these are the different types. So for early after, you have phase 2, phase 3, and then we have the delayed after. Okay. So with delayed after repolarization, what we are saying is that repolarization has occurred. Cardiac action potential is in phase 4, but what happens is that there's triggered action potential, cardiac action potential occurring. And this is mainly thought to be due to overloading of cells with calcium. Okay, and this overloads the sarcoplasmic reticulum, which releases calcium into the cytoplasm, and therefore making the cardiomyocyte more positive and driving it, the membrane potential towards positive. And once it gets to about 60 thereabout, and we know that sodium channels are also being activated, then it can trigger depolarization. So delayed after, mainly due to overload of calcium in the cells, and anything that can lead to an overload of calcium in the cells can lead to a delayed after depolarization, and it's mostly either calcium that is not released or calcium that is released from the sarcoplasmic reticulum. Okay. And usually it will happen transiently. And then once it is huge enough, the oscillation is huge enough, it can trigger the delayed after depolarization. Okay. So, like it says, simplest form, delayed after depolarization is a voltage oscillation driven by oscillations in what? Intracellular calcium ions. And that can lead to that. And a few things to remember here. One, cardiac glycoside toxicity. Let's remember the sodium, potassium, the ATPase channel is one. And there's also, that is coupled to the sodium potassium exchanger. Okay, it is coupled to the sodium potassium exchanger. All right, so once you inhibit that, there's a accumulation of so you inhibit the sodium potassium when the ATPase, the sodium potassium ATPase. Okay, so what happens is that you usually are sending what? Bringing, so there's counter exchange. So then you need to find a way to get the sodium out of the cells. Okay, so then what happens? Then it also affects the sodium potassium current. So you now have, it becomes a counter current. So calcium coming in and sodium going out. And that leads to the sodium calcium accumulating in the cells, and that can trigger that. Ventricular arrhythmia is related to outflow tracts, myocardial ischemia, acidosis, hypoglycemia, and then particularly the catecholaminergic polymorphic VT is also due to an overload of calcium, and that is because of a defect in the ryanodine receptors of the sarcoplasmic reticulum. There's an overflow or overloading of the cell because of the defects in that receptor. Okay, so I mentioned digoxin. So digitalis. So once it inhibits the sodium potassium pump, accumulation of intercellular sodium, and the enhancement of what? The sodium potassium exchanger in reverse mode. So 3 sodium out, 1 calcium in, then you have accumulation of calcium. Then the catecholamines, like I mentioned, also do that in different ways. Okay, in different ways. Myocardial ischemia, I mentioned, also does that, and that is because of a defect in metabolism. Once there's myocardial ischemia, decreased ATP affects the sodium potassium channel, and then that can also affect the sodium potassium calcium exchanger, leading to calcium overload. And it is also known that generally myocardial cells that are ischemic also tend to have calcium released from the sarcoplasmic reticulum, and that also leads to that. And then the catecholaminergic polymorphic VT I mentioned, ryanodine receptor defects. Okay, then there are drugs that can inhibit based on the pathophysiology of this activity. So calcium channels and beta blockers reduce the inward calcium current and intracellular calcium overload. Okay, so they would sort of inhibit this, and that's why you can use beta blockers and calcium channel blockers in some of these conditions. Okay. Lidocaine, phenytoin, especially lidocaine, reduce the inward flow of the sodium channels, and that is why it is effective in patients who have myocardial ischemia and are having ventricular arrhythmias. Okay, then let's look at the early after depolarization. So these occur during the action potential plateau, that is phase 2, or late repolarization, like I mentioned. Okay, and usually they tend to occur commonly when the action potential is prolonged. And once it is prolonged, it allows more time for the voltage-gated recovery, especially the long-lasting calcium channels. Okay, so once there is a delay and these sort of begin to open, then they can what? lead to depolarization of the action potential, even though we said that, especially during phase 2, it tends to be what? Refractory. That is because there's a counterbalance in the flow of ions. But if that disruption occurs, then you can have an action potential occurring. So even though it is absolute, it is not absolutely true that nothing can happen. Once there's a disturbance in the flow of the ion channels, then you can have an action potential being generated there. Okay. Okay. All right. So I think I showed this image already. Okay. So like I said, any factor that transiently shifts the net current in the inward direction can potentially overcome the reverse repolarization. Okay. So that is what I explained earlier on. Even though it is said to be refractory, once there is a shift, we can have mechanism there. Okay. So what happens is that reduced repolarization usually is not sufficient to produce this, okay? But then you tend to have other factors that generate some of these oscillations. So you need some certain things to contribute to it, okay? So the one important thing is the ions that are involved, the calcium, sodium, and potassium channels, okay? So if you usually have a prolonged action potential, what happens is that at a certain voltage potential, these begin to be activated. And we mentioned that the sodium channels begin activated once you are going down the slope. You also have the long lasting type calcium channels also being activated towards the end. And then you also have the potassium slow. Those are the slow potassium channels also in that range. So once these all come into play, there is a critical window period where you can have what? An action potential being generated. Okay, so if we look at this diagram here, the action potential is short. So the calcium channels, even though there's some oscillation here, they are activated. They do not produce an enough trigger to cause another action potential. Okay. But once you delay it, then what happens is that you have more of the what? Long-lasting calcium channels being open. And that means that the amount or the load of calcium that is going into the cell is going to be higher. And that can what? Trigger an action potential. That can trigger an action potential. So that is what happens. And mostly, like I said before, delayed or early, usually due to calcium overload. Okay. So one of the main conditions or the fundamental is the action potential prolongation. Okay. And on the ECG, we see it as QT prolongation. And that is one of the foundations of the early after depolarization current that we have. Okay. And some arrhythmics antiarrhythmics can do that because their therapeutic effect is to what? Prolong the action potential. So the class 1A and the class 3 typically can do that. Okay. And then other conditions that lead to bradycardias, like hypokalemia, can also do that. Long QT syndrome can also do that. These are other etiologies that we have. So quite a lot of conditions can do that. And all these sort of affect the prolongation or the length of the cardiac action potential. Okay. So so in the delayed, the main issue is what? These channels here. So this is a sodium calcium exchanger. So what happens is it is in reverse mode. And once there's calcium, triggers this to release calcium into the cell, and you can have that. Again, you see that there's calcium overload here. Okay, and this is because these are acting, like I said, calcium is going in, sodium is going in, and then potassium is pushing these out. Okay, so once these sort of create an imbalance in the membrane potential of this high enough, then it can trigger this early after repolarization. But the fundamental ion imbalance here is calcium overload via different mechanisms. Okay. So we'll look at re-entry. Okay, so re-entry usually means that there is propagation of current within a certain space. Okay, so the normal thing we know is that once there's an action potential, flows through the AV node, then to the Purkinje, and then the entire heart is what? Activated, and then depolarization is completed. Okay. What happens is that if there is a delay in the depolarization or is slow, and the normal depolarization has occurred, and this one is slow, when the others have repolarized completely and are ready to depolarize, the one that is slow or was not activated during the initial flow now what can be a source of an action potential to the fibers that have been what? Depolarized and are now repolarized again. And once that happens, it triggers, and then they become what? Depolarized, and then repolarized, depolarized, and repolarized. And that can lead to what we refer to a re-entry. Okay, so it means that the tissue is depolarized and repolarized, repolarized, depolarized, and that creates a trigger. So that is basically the mechanism of a re-entry tachycardia, a re-entry tachycardia. So there's repetitive wave activation. Okay, so because it's slow, so once it activates the tissue that is repolarized, it goes around, comes back to it. It is delayed again. So by the time this one is repolarized, resting again, it triggers it again until something interrupts that cycle. Okay, so I mentioned that we have anatomic and functional. So anatomic means that there's a physical obstruction to the flow of the activation, and that sort of propagates or initiates the re-entry. And then functional, there really isn't any physical. So when we say physical, it can be a scar. So a scar is a physical anatomic re-entry, cause of anatomic re-entry arrhythmia. And then when we take something like let's take something like Brugada, it's sort of a functional, but now they even think that there's some structural components to it, which means that an area, okay, of the cells do not depolarize as early as they are supposed to depolarize. Okay, and in Brugada, it is because of the sodium channels. So they do not depolarize as they are supposed to. There's a delay in depolarization. Current has to flow around. Or even if you take myocardial infarction in the early phases where the disease is hypoxic, that can also lead to a functional re-entry. And for the functional, let's remember that there are different types. There's a leading cycle, there's a figure of 8 reflection, and the spiral forms. Okay, quite a bit technical, but just remember that these are what we have. So for you to have a re-entry arrhythmia, let's remember these things. You need a substrate, okay? You need a substrate. So you need the presence of myocardial tissue that has different electrophysiological properties, conduction properties, and refractoriness from the normal tissue. So when that is there is a potential, that is a substrate for a re-entry mechanism. Then you have an area of block, so which can be anatomical or functional. Like I mentioned, A scar is anatomic. A condition like Brugada or early initial phases of MI can be functional, or you can have both. Okay. An area of tissue which is inexcitable, okay, or is slow. Then you have unidirectional conduction block. So it means that current cannot go through in one direction. It has to flow through another direction, but can come back through the other way. That is a unidirectional block. That can also trigger a re-entry phenomenon. Then, apart from the block, you can also have slow conduction. So that it is so slow that by the time it goes through another action potential or activation waveform has occurred in that area. So, and then you need an initiation trigger. And in most cases, it's usually an ectopic, beat that can trigger some of these things. And so we have examples of these. So this is a block here. So it has to go around. And then if it's unidirectional, can come through. This is an example of that. Goes through like that. And then this one is slow, but you can have it going through again. Okay. When it's bi-directional, usually you won't get a block because it blocks it. So it just goes around it and continues. Okay. So that was I was explaining the re-entry mechanisms. Okay. So I'll just look at this and then we can end it here. So for the re-entry to be propagated, what you need is the head and then the tail. So it is like a dog chasing its own tail. Okay, so what it means is that once you have this one triggering the arrhythmia, the tissue before it is repolarized. So it means that it can depolarize it. Okay. But then you have this waveform going through like that. So this one gets depolarize, repolarize. So until this cycle is broken, you continue to have a re-entry phenomenon occurring. And that is where you can have, you will have what do we call it? That is when if you have an ICD, actually can do that, and usually has different mechanisms of doing that. Okay. So you always need an excitable gap to propagate it. Once you break that chain or you widen or increase the excitable gap, then you tend to sort of prevent the re-entry phenomenon. Okay, so functional, there's no anatomic obstruction, but it's just due to changes in electrophysiological properties in the tissue that we have. Okay. So these are different ones we can look at. Okay. So common examples, re-entry, we have atrial flutter, ventricular tachycardia, AV nodal re-entrant tachycardia, atrial fibrillation is a form of re-entry, micro wavelets, automaticity, atrial tachycardia, accelerated junctional rhythm, and then the triggered activity, torsade, long QT syndrome, and then the delayed after depolarization, the bidirectional VT from digitalis from digitalis toxicity. You can have ischemia also happening and the outflow tract obstructions. Okay, so I think we can end here, and these are the references. Thank you very much.
Thank you very much, Dr. Felix Arindango, for such a detailed presentation. We are very grateful. We like the way you were able to break things down and then to the basics. We are very grateful for your presentation this evening. Please, at this point, we would open the floor for contributions, questions as well.
Good evening, sir. Thank you for the lucid presentation. I think at some point there were some internet glitch on my part. I just wanted you to throw a little light on significance of the transit calcium channel. I think you talked extensively about the long opening calcium channel. So I'm just maybe a little insight into significance of the transit calcium channel. Thank you, sir.
Okay. Yeah, so thank you so much. So the transient, like the word says, they are usually transient. Okay. So they are usually involved in the pacemaker activity of the cardiac myocytes. So in the SA node, they are involved in the early repolarization phase of the sinoatrial node or the AV nodal activity. They are also present in Purkinje fibers. So the phenomenon of escape rhythms. So when the SA node fails, you presume that the atrial tissue will take over, and that is because they also have intrinsic, what do you call it, nodal pacemaker activity. And that is mainly because of some of these, what do you call it, IF currents. They are there in the atrial tissue. They are also there in the AV node. And then you also have them not in the cardiac myocytes, but in the Purkinje fibers. And they are involved in the escape mechanisms that we tend to have. Thank you.
Thank you, sir.
Thank you so much, sir. Please, sir, can you throw more light on the reentrant mechanism where you talked about the unidirectional and some other ones? I didn't get it, please. Thank you.
Okay. All right. So let me just see. Okay. Okay. So with regard to the reentrant tachycardias, what you need to, so these are let's look at the mechanisms. Okay. So one, like I said, you need substrate. Okay. So it could be physical or it could be what? Electrophysiological or functional. Okay. Then you need an area of block, a tissue that is not excitable. Okay. Then a unidirectional conduction block. So what that means is that current cannot flow in one direction. Okay, so it means that, let's take this for example. Okay, so let's take this for example. I hope you can see the pointer.
Yes, sir.
Okay,
Yes,
good. All right, so you see in this, the current can flow here. The activation potential can flow here. Okay, and once they flow through and come through, they cancel each other. So this cannot go through this, and this cannot go here. All right. But you have this where there's a blockage here. There's a unidirectional conduction block. Okay, so this cannot flow through this. Okay, so this can go through this and go through this. But there can also be reverse flow. Okay, here, bidirectional, which means that even though the current cannot go through this, that's in one direction, it can come through this direction. So once that is possible, this current comes through here and can go through this and then trigger a re-entry phenomenon here. Okay. What happens here is that here, for instance, there's a complete block. So it can't go through this. So it's a bidirectional block. So a bidirectional block usually does not lead to a re-entry arrhythmia because the current comes through here and flows through this way. If it goes through this, it cannot go back. It is blocked there and it ends there because it doesn't come back. But if it's able to go through this, then it creates a re-entry phenomenon. So that is the idea behind the unidirectional conduction block. Then you also have the slow conduction. So the slow conduction means that, let's say it goes through this, but it's very slow. So by the time it goes through this current has come through and it's gone already. So what happens? It means that the tissue here has repolarized and there's potential for depolarization. So this one coming here can depolarize this and create a re-entry phenomenon because this is depolarized tissue, okay, and create a re-entry phenomenon in this area. Okay, so I hope that I was able to explain it.
Yes, sir. Thank you so much, sir.
Thank you.
Thank you, sir. Sir, there's a part of the presentation where you were talking about drugs, beta blocker, calcium channel blockers, inhibiting a particular mechanism. I didn't understand where the calcium channel blockers come in as
Okay.
beta blockers.
Yeah, so it has to do with the mechanism of the medications. So ivabradine, we all understand, affects the IF channel, so sort of inhibits the IF channel. Okay, so the IF channel doesn't depolarize as it's supposed to be, so that can slow the heart rate down. Okay, then the mechanism of the beta blocker usually is to stimulate the G proteins, which leads to stimulation of the I think it's phosphokinase A, if I remember. And that leads to hydroxylation or hydrolysis of ATP to ADP. What it does is that it releases calcium within the myocyte, okay? And the calcium within the myocyte causes contraction, okay? One is contraction, one is increase in heart rate. That is the what do you call it? The sympathomimetics, okay? If I should say that, norepinephrine and the like. But then the beta blocker sort of counteracts this activity. So the beta blocker inhibits the release of calcium from the sarcoplastic reticulum. So it sort of reduces the amount of calcium load that you can have in the cell to trigger an early or delayed after depolarization. Okay. The calcium channel blockers also work in a similar manner because let's remember that calcium channel blockers have different effects, but they affect the long-acting calcium channel blockers. Okay, so what they also do is that they also inhibit these calcium channel blockers so that they don't lead to the influx of calcium in the cells. And you remember that if you look at the excitation coupling, the sarcoplastic reticulum releases the calcium based on its activation by calcium. So when you inhibit calcium, then it means that you are blocking these two mechanisms. So you tend not to have calcium overload within the cell. And once calcium is reduced or inhibited, then again, it will what? Slow the heart rate down and can also what? Slow contractility. So that is how the calcium channels come in here. Then the other mechanism is the phenytoin and lidocaine. Those are also known to inhibit some of the calcium channels. So there's also reduced calcium influx in cases of patients with myocardial infarction. And then that also prevents the arrhythmias or the VTs that they tend to get. Thank you.
Thank you very much, sir. It's clear now.
So.
Please, any more comments, contributions? Okay, if there are no more comments or contributions, we'll move on to our consultants and facilitators. Please, Dr. Ojo, please, any contributions for us?
Go on.
Yes, please.
Yes, I don't have any contribution, just to appreciate the presenter for the job well done.
Thank you very much.
Thank you.
Thank you. Thank you.
Okay. Dr. Asian. I don't know what that is. Okay. Thank you very much. I'm still trying to see if we have other consultants on the call, but I'm currently not seeing any. Okay, so we thank you very much, Dr. Felix, for such a wonderful presentation. We are very grateful that within this short time, we're still able to put things together and come and present. We are very grateful. Thank you very much.
Sure. Thank you too for the opportunity. Anytime. Sure.
Please, at this point, to move on to the second aspect of our task for the day. We are going to continue our MCQs. And I think the last time the questions were shared up to question number 30 for this section. So we need to at least finish that first 30 questions of the section and continue tomorrow. So we have to hasten up. So I'm going to share the questions, then we take it from there.